And then we're going to talk about some of the duration and maintenance and how long we should go. And we'll go from there, and we'll see. This may run just a little bit long. So if somebody's got a case, I want to make sure I can just cut this a little bit short, but I'm just going with the idea, if we don't have a case, I'm just going to plan to run a little bit long and then have a discussion. So we've got a couple different preparations. We've got the film and the tablet. For the most part, when I'm in the addiction clinic, this is largely driven by what the insurance will pay for. I have not been able to figure out what insurance pays for the tablet and which one pays for the film, and they need to. And so I typically just allow pharmacy to make the substitution as they are needed. The films tend to dissolve a little bit quicker. And individually wrapped. One of the warnings that came out, I want to say a little over a year ago, was the increased risk for dental caries of the sublingual product versus like the injectable was what the clinical trials are doing. What I do, what other experts on some of the NIH grants that we've worked with on this is we're just recommending routine dental care. In another project, we've also talked to people on the New Mexico Dental Board, and that's kind of what their approach is just to watch, and it's just a watch and wait for that. But just with it being kind of a change last year, I just kind of wanted to highlight that. So as far as treatment options, we have the sublingual and we have the injectable or the implant. I put the I believe it was last week's session, I put the REMS information for the injectable for both Brixadi as well as Sublocade in the chat, and they're both found at the manufacturer, and that's per Board of Pharmacy. I think with our experience on the hub team, that's the biggest impedance is, do we have a REMS pharmacy? At UNM, it's a little bit easier at the ASAP clinic because we do all the REMS. As far as the self-administration goes, while it's flavored, most patients also comment that it has a bitter or not a fun taste to it. But it's widely accessible. We worry about diversion being a risk, and we worry about cost. I tend to find that my younger patients, those under the age of 25, those that I am concerned with diversion, do better with the injectable and not having to remember it. One thing I've learned about snake bites is you can't suck the venom out. So I also extrapolate that into you can't suck the bupe out of belly fat either. So there's a few different ways I'm going about this. And so the first one is we're going to talk about what does the package insert say? And the challenge here is wait until the patient feels very, very lousy. We have the subjective opioid withdrawal score or the SOWS score we can give patients, but the challenge here is getting patients to be in enough withdrawal that they're willing that they can wait long enough. I've had several patients who have not been able to have broke down and used in this time frame. The ideal standpoint is that we wait 12 hours since their last dose of their short opioid acting, or at least 24 hours since they're long acting, to help really ensure that they're in an appropriate level of withdrawal. We're targeting that SOWS score, like I said, of a 17 at a higher level. And then starting with a 4 milligram dose, I'm fine too, having the patient start with like a 2 milligram or a lower dose too. But generally speaking, the goal that we're going to arrive at is going to be 16 milligrams or above. And some of those home inductions, I think my patients, their sense of time and their sense of dose is not the same as mine because they're feeling so miserable. And then what we're trying to do is avoid that precipitated withdrawal there. And I think those of us who've initiated buprenorphine, most of our patients have been on buprenorphine, and with them being on it, or having tried it on the streets, some of them have had that unpleasant precipitated withdrawal and don't want to go back on it. But oftentimes an education does help. As far as on day 2, we take the total of in the morning of day 1. We'll have them check in on the clinic. I think this is an ideal way of doing it. When patients with substance use disorder come to you and begin treatment, they're usually at their sickest. And as we maintain them in treatment, they will get better. So a lot of us in primary care will call and check in on a patient periodically when they're really sick or at home or nearing death and in the family. And knowing this is kind of that reverse process, we're just going to kind of check in with them in a day or two early. And they're usually 5-minute or less phone calls. Hey, just wanted to check in with you. How'd the induction go? Things went good. I'm feeling better. It's like, hey, that's awesome. Thank you. Let's keep doing it. Let's make our appointment next week or the following, and we're going to dial that dose in a little bit. If they're having problems, we can make a bit of an adjustment. And then if you guys have problems too, or you're busy, you're always welcome to have them give us a call at the Poison Center. Sergio's on here, so between Sergio, myself, and Eric Ketchum will sometimes join us. But the three of us have taken addiction call here for the last 3 years straight, and we're continuing that, and that's kind of a unique thing here for us in New Mexico. The goal on the package inserts getting people up to 16 milligrams. Letting the cat out of the bag. In the fentanyl era, we're finding that 16 milligrams is not sufficient for the majority of our patients, and we're having to go above that. As far as on hospital day outpatient day 3, again, whenever we have the time to touch base with them, is generally preferred, but not necessary. And the package insert does use the word quickly to titrate them up. So again, we want that to get them up to 16 milligrams pretty quickly. And then if they're starting to have oversedation, which I have not done and had experience ever in somebody with substance use disorder, I have seen people develop with chronic pain, some sedation with doses just under 16 milligrams. That would be a reason to maybe back down a bit. How long to wait? This is, we generate this theoretically based on how long the opioid is acting. Again, this is in the package insert, but ultimately, I think at the end of the day, look at the patient, evaluate the patient, and how's the patient doing clinically, in my mind, trumps this information, how long to wait. As far as the transition from methadone goes, I think this is always a little bit tricky. This is one, as Sergio and then I'm not sure of Vanessa Snehal, we've done several times. But having done this, I'm again still saying this is tricky. Again, at the Poison Center, we're happy to to help you walk you through this, but generally we try to. And the package insert and the historic way of doing this was to wean the patient down on methadone to less than 40 for a week, and then have them stop it, wait for the withdrawal symptoms, and then introduce it. I don't want to spend much more time because, frankly, at this point in my practice, we'll see what I see Sergio on camera and he can give me a thumbs up. But I'm really doing a low dose induction with my methadone patients. They just tolerate it so much better. While it feels a little bit uncomfortable to gloss over what the package insert and what we've done historically, I think I don't want to go back personally. So another big thing here is with precipitated withdrawal is that we can, I want to talk to my patients and I want to advise them and have a plan to go if they start withdrawing. So if a patient starts withdrawing, not to freak out, to let us know, and or for them to know, I usually give them have them consider some clonidine, some ondansetron, hydroxyzine. I always like asking my patients, when you withdraw, what bothers you the most, and really kind of target a med or a drug to what's bothering them the most as they do that. And once yeah, and then just kind of pre-treat it. I tell the patients in 2023, 2024, if the withdrawal gets to be too much, you need to tap out and you need to use, that'll get you relief. But and I get that, but then give me a call back or let me know, and so we can walk you through what to do, and I'll on the following day. And a lot of this is we're really converting over, and where this is going is to the low dosing approach here. So as far as maintenance dosing, this is a copy of what Snehal refers to as the Bernese method. Actually doing the literature search on this, it comes back to us the original paper that Bernese wrote as a case series or a case report of 2 patients, and both patients actually had a different dosing regimen. There are and now because everybody's got their own dosing regimen out there. I think there's a new one of these published at least 3-4 times a year where somebody's validated a low dose. And there's always variation. So my take is I actually start with a 0.5 milligram and have for a long time, just and more of a just comes down to, how many times are we going to cut that strip up? And we generally write for 2 milligram strips, and we can cut it like into twice or into fourths, and they can start with that. I haven't had any bad outcomes yet with an induction of 0.5. If Sergio, Evelyn, or somebody else in the hub team has had a challenge, let me know, because I think we want to watch for those. And then I basically take that dose and double it every day. What I've is my concept of it. What I've actually been doing over the last year is basically talking to the patients and saying, like, look, I'm going to give you this 0.5 milligrams. And one of 2 things is going to happen. If you're having some withdrawal symptoms and they get better, like, great. And if they're not completely better and you want to take a little bit more or another 0.5 milligram, go for it. But if that's making you worse, don't take any more today. We're going to do the same dose tomorrow and you're going to be fine. And that's one where if we use our adjunct medication, that will help. If you need to tap out and you need to use, again, I just like knowing if you've had to use in that, and we can adjust the plan. As far as maintenance dosing goes, FDA has approved up to 32 milligrams. There's us on the hub teams, with being Sergio, myself, Snehal, we participated, and we're ending a NIH clinical or NIDA funded clinical trial where we compared 16 versus 32 milligrams compared to an injectable product. And again, that 32 milligrams, it's a non-blinded study, I can tell you, is superior to the 16 milligrams in a multi-center study. But the challenge is most insurances will only cover up to 24 milligrams. Usually when a patient's struggling on the 24 milligrams, we've been asking for the prior authorizations, and at least from the addiction clinic, not having a lot of pushback from insurance denying the cost of the 32 milligrams. But those of you in the community working, if you've got a different experience, I would request that you share that for us. As far as the duration goes, and how long people are on it, I think the standard of care is that the patient's on it as long as they feel that the drug benefits them. They will, the studies that have been done up to this point have gone out to 1 year. Anytime we start withdrawing medication within 1 year, we start having relapses. We have people not showing up to visit. This is also demonstrated in the early 1970s when methadone was first approved for detox, and then shortly thereafter was approved for maintenance, just because we get all these people through detox with methadone, then they'd go right back out to the street and start using again to satisfy cravings and stuff like that. I typically will write my first prescription. I like to personally follow a patient up in 1 week, but there is very good and valid literature supporting 2 weeks. There's one study, and I can pull the reference if you guys want it, but suggesting a 2-week follow-up was better than one. My logic for a 1-week follow-up is oftentimes I'm doing a dose adjustment at that 1 week and just checking in. And then basically, as the patient tolerates or as we begin trust with the patient or they're in recovery, start moving those off. And my stable patients, right of a month's worth and then a 1 month refill, and then see them basically every other month. As far as diversion management goes, this is where drug screen comes in. I think it's an error in medicine to make a clinical decision solely on a drug screen. So when my results come back not fitting what I expect for a patient, I have a chat with the patient and I say, hey, I was surprised to see that you had your opioid screen was positive and your buprenorphine was negative. What do you think of that? In a constructive way, and really trying to give the patient that opportunity to provide an explanation. If they don't, or we're uncertain, I say is like, look, I know the test isn't perfect. We're going to ask them to confirm the test, and it's going to take them a few days to do it. So let's meet back here in a week and we'll discuss it. And then that gives me time. It gives, I think, the patient some time to think about, what had happened. Because sometimes it's just the shock on it. I also usually utilize this as a point where the patient's not trusting me enough or trusting the office or the staff enough to be honest and start asking the question why, and do we need to start building some trust? And so that's not the point where I want to withdraw medications. If this becomes a recurrent problem, then at ASAP, we've got the benefit of daily dosing and coming to the window and controlling that. But that's also a time when I start making a move to one of the injectable products. We've also have the 48-hour callbacks. Basically, the way this works is we say, periodically you're going to get a call, and at that point you bring in what all of your script or the drug. We're going to do basically a film or a tablet count, make sure that's there. The storage and safe lock boxes, I think all of our methadone patients who have take-home methadone, we send home with a lockbox. Methadone at the poison center is on my 1 pill or drink can kill list. 1 ml of methadone has 10 milligrams of methadone in it. So we can get up to high doses really quickly. That's done to prevent cheeking. But what we have seen as buprenorphine is more widely out there and for treatment is that we're seeing more children getting into buprenorphine accidentally and putting that strip in their mouth, and want to make sure that we're preventing that. So this is the microdosing or low dose induction. Like what we said, we have what was originally described as Bernese. I'd also just like to point out that what Bernese did was a transition from methadone to buprenorphine. In a pain patient and not in an addiction, just for additional things. But this is the standard of what we're doing, just because so many patients just struggle to be miserable. And the idea of, hey, we're really glad that you're in the clinic. I know you're working the rest of today and you're working all day tomorrow. When are we going to get started on the drugs? I want to get started now. I know you do too. And let's not try not to delay that. Just going back to Evelyn's talk last week on motivational interviewing and really surfing the wave and maintaining the momentum. The idea is that with really low doses that we don't get into inducing withdrawal initially. And that over the course of a week, as we increase those doses, we get more and more binding with the buprenorphine on that receptor. We've satisfied those cravings. Generally, what happens is the patient is instructed to continue. They're okay to continue to use. They come back to you after a week and are like, yeah, I was doing probably 20 blues a day, and now I just did one yesterday. And I really hadn't thought about how much we were cutting down during the induction. And then ultimately, it's controlling those withdrawal symptoms is is our first priority, and then second, usually as we start going up on the dose, is to control the symptoms or their cravings. So I said we'd come back to some of the methadone and the on the on methadone, the conversion. Most of the time, again, give us a call if we're needing to do this in the outpatient setting. If they're getting methadone, they're at an OTP. And somebody again like us with the hub team doing that. And again, we're more than happy to walk you through this, but usually it needs to be in coordination with their OTP as they drop their dose down. I usually like to drop the methadone dose down by a good 25 or 50%, and then do that really low dose, usually starting at 0.5 or 0.25 milligram on the first day, and see if the patient can tolerate it. So role of buprenorphine is one of the things that we have been seeing in New Mexico, and is really, as I feel like it's forced our hand into doing this low dose induction method, is this buprenorphine refractory treatment. I've certainly had, and not recently, but a growing case series of patients that we've given well north of 30, 50 milligrams of buprenorphine to. I had a 13-year-old that got nearly 100 milligrams of buprenorphine and was still having a cow score well over 10, not being touched by the patient, and really what to do with those situations. Interestingly enough, we struggled with this for a couple of years, and it became our OB docs who kind of figured a plan out. And basically they would just administer morphine or hydromorphone in the hospital as kind of a rescue medication. And to do it, federal law doesn't allow you to give a Schedule II to treat opioid withdrawal. So I know at UNM, our people, and same thing with my counterparts in Hispaniola, as well as our colleagues at the Loveless Women's, we've always been documenting the patients experiencing pain, and opioid withdrawal, I think, is a painful condition as well. So just some other tricks and tools that we've done over the years. So again, that microdose induction, it's kind of like barbecuing. Start low, go slow, and know that this is going to take some time, and to do it. I feel like I've been over this a few times, and just different dosing strategies that are introduced in the literature for you guys to look at. Usually have a little bit of a cow score. All right. And then, so as far as the duration of maintenance, and I alluded to this earlier, is that we want to keep people on it as long as they feel that it benefits them. When we start withdrawing it, patients come down. Again, Sergio, Snehal, and Vanessa helped a bit too with an ongoing clinical trial sponsored by NIDA, where we were looking for people who had been stable on buprenorphine for more than a year and then cutting off. And this was really interesting, talking about some preliminary results, as the paper hasn't been published yet. But it was amazing at how you have some of these people with their lives really back together, and they were super motivated or wanted to come down. We had some patients who were able to come down, others who were like, man, I just wanted to go right back up, and we're not going to try that again. But I think the point is we want to support our patients and meet them where they're at. I think as far as how we do the taper, how we do the discontinuation, I like to give the patients a lot of room or control when they're on the film or the strips, and to cut down. It's not a race. I don't have this in the slides for this presentation, because this usually goes a little bit long. But when we withdraw patients, and especially in the pain setting as well, is that's an increased risk for relapse. That's an increased risk for death. That's an increased risk for basically a acute mental health crisis defined as a hospitalization or an overdose attempt. And so I have some of those talks with the patient before, and then work to essentially taper them down as the patient tolerates. What also becomes interesting, and we see this with methadone too, is that we get the patients down low, and just getting them like from 4 milligrams off is oftentimes like the hardest part for them to tolerate. And I'll just keep them on those low doses as long as they're wanting that dose. Yeah. With the injectable product, most of my patients will deny having any precipitated withdrawal symptoms as the delayed release or injectable product comes out of their system. Given the high relapse, high overdose rate when we start coming down to, that's a time when I start trying to follow up on my paper or on my patients closely. And then I also do talk to them about at least starting naltrexone for a few months afterward, just to make sure that the cravings and stuff are gone. And then I counsel the patient that they've lost their tolerance as well. And that if they were to go back and use to start really low and to go slow and not to use alone, and the harm reduction things that go with that. So with that, I'm going to stop my share. I'll open up to questions.